Well, hello, everybody. Welcome to the December 17th, 2025 um, episode of Topics in Trauma Nursing. I'm Steve Wyman, and I will be your host over the next 45 minutes or so as we talk about this very unusual case presentation that came into my trauma center about 18 months ago. So I hope you'll find this case as interesting as we did in our trauma bay the day this person came in. And hopefully will enlighten you a little bit as to this case of parkour induced trauma. What the is parkour? So this is a re-recording of a talk that I gave on the 17th. Unfortunately, YouTube didn't like my video very much. I had embedded some videos from The Office where they actually did kind of a comedy routine about parkour, and because of copyright and all that fun stuff, YouTube rejected it. So I'm now re-recording it sans that unfortunate little video being taken out. So at any rate, so again, welcome to Topics in Trauma Nursing. If you haven't participated in any of the videos related to topics in trauma nursing in the past, basically what this is a quasi quarterly educational offering. And my goal is to bring cutting edge and hot topic and interesting cases, as in the case tonight, of trauma care or emergency care to emergency and trauma nurses. Initially, it was to nurses here in New Jersey, because that's where I'm based out of. But obviously, we are on the World Wide Web, so we certainly go beyond. And there are not a lot of subscribers to my YouTube channel, which, by the way, if you like the video tonight, please subscribe. Um, but enough to where there is an international smattering of individuals and individuals from across the country who do tune in. So I thank you for that. So the goal is really for you to sit back, enjoy, and in the live session, I encourage you to ask questions. But since this is a video, I certainly would tell you to put your comments in the comment box on YouTube, or I'll give you my email address. And certainly, I'd love to hear from you, particularly if you have taken care of a parkour or a patient who was practicing parkour who comes to your facility. There's not a lot in the medical literature with regards to parkour and parkour injuries. So the more that I hear from people, the more I'll get a better appreciation for it. And my goal is to write this case study up and get it published, which I'm going to be working on, and we'll get it out there in the limelight. Again, all sessions of topics in trauma nursing are recorded and housed on my YouTube channel. I am the Trauma Geek. Obviously, you found that out by finding me and finding this video. So I appreciate your taking the next, again, 40 minutes or so and listening to what I have to say today. Oh, no continuing education for this. Sorry, this was for the live session. I do want to give a shout out because we are still months away, but I do want you to mark your calendar, particularly if you are in the New York, New Jersey, Pennsylvania, Delaware, or Connecticut area. And you don't have to be in just in those areas, anywhere in the country or anywhere in the world for that matter. But I do want to bring your attention to the 47th annual Emergency Care Conference, sponsored by the New Jersey State Council of ENA, Emergency Nurses Association. We will be at the Hard Rock Hotel and Casino in Atlantic City, March 18th through the 20th. ECC is a phenomenal meeting. It's the second largest meeting of emergency nursing in the United States, second only to the national conference held annually. We garner somewhere around 450 plus or minus like-minded emergency nurses who come and get together for a couple of days of great education. A lot of different topics, a lot of great speakers. So do please mark your calendar. Not a lot of information available now. We've just kind of started to finalize the speakers for the conference, but over the next couple of months there will be some things that are posted or on NJENA's website. So for additional information, certainly just go njena.org and you can keep an eye on that. But certainly do mark your calendar for that couple of days. It is an excellent conference. And for those of you that are in the Northern New Jersey chapter of ENA scope area, I do want to invite you to attend a watch party for the second season premiere of The Pit. This will be on January 8th at 6:30 p.m. At my shop, which is St. Joseph's University Medical Center in Paterson, New Jersey. The QR code there and the link will take you to a registration page. And if you do want to come and spend some time with us and watch the first couple of episodes for the new season of Pitt, which I absolutely just love, please do come out and hang out with us and enjoy. Great TV show. If you haven't been able to take a look at it, I wholeheartedly recommend you look at it. It certainly does bring what we do to the public in a way that has never been done before. And it's garnered a lot of critical acclaim because of that. And not critical acclaim on just the layperson side, but from those of us that are clinicians and practicing this and doing this on a daily basis. So again, if you're going to come out, you're in the Northern New Jersey area, hit that QR code and we will be in contact with you. All right, let's talk about what we're here and what you tuned in to look at today. The case of parkour-induced trauma. What the is parkour? So I'll introduce myself. For those of you that don't know me, my name is Steve Weinman. I'm with the trauma program at St. Joseph's University Medical Center in Paterson, New Jersey. We're a busy urban level 2 trauma center in the northern portion of New Jersey. And I'm thrilled to be able to bring you this extremely unusual case study that hit our trauma bay, like I said, about 18 months ago. This is a reprise of a talk that I did give at the Emergency Care Conference in Atlantic City back in March of this year. Excuse me. All right, I have nothing to disclose. All right, so the objectives here, first of all, is discuss what the sport of parkour is, and then parlay that into understanding how individuals who are deviating from the true sport of parkour are getting injured or may get injured and may present to your hospital. We'll review this particular case that brought this sport to our attention. And then also we'll talk a little bit about what I've been able to glean from the very limited literature and speaking with other clinicians who have taken care of patients who sustained parkour related injuries, as to what the injuries were that they saw, and then compare and contrast the injuries that we saw, and then certainly what you can expect based on the overall mechanism of their injury when they come in to your facility. All right. So what is parkour? At the end of the day, it is actually an athletic training discipline or a sport in which its practitioners, which are also called tracers, attempt to get from one point to another in the fastest, most efficient manner possible. And they do this without using any assistive equipment and often while performing feats of aerobatics. It's also called free running. So parkour, free running, one and the same if you've heard of either of those terms. The literature or the limited literature talks about it originating in the 1980s, and that's the true sport of parkour, I think, kind of emerged in the 80s. But as we'll see in a minute, it actually has been around for quite some time prior to that, almost a little over a century. When it kind of blossomed as a sport in the 1980s, it was originally called l'art du déplacement, obviously some French dialect there, so it came from France, and that's where it originated back in pre-World War I, which we'll talk about in a second. And later the name evolved into les parcours, and of course now parkour or free running. When we look at the true roots, we can trace it all the way back pre-World War I. French naval officer by the name of George Herbert was exploring areas of indigenous Africa and noticed some of the tribes in these indigenous areas were doing these kind of obstacle-related courses that he found fascinating. They were really kind of doing interesting things. They have almost defying gravity, was what he wrote in his paper. And he also found out that the tribesmen that were doing these activities were extraordinarily well fed, extraordinarily. So what he did is he took copious notes of what they were doing, and he ended up bringing this back to France when he went back. And he actually developed a military obstacle course based on this, which he called method and natural, or the natural method. And he started putting his naval officers and his naval individuals through it. And they became extremely well fed. Post 1980s, parkour was blossomed in its overall appeal, and it actually appeared in a number of high-profile movies. It was in one of the Bond films. It was in one of the Bourne movies. It was in a Die Hard movie, and it was in a couple of other movies. And again, it's out there. It's got some, good media spotlight on it, which kind of fueled the fire of people practicing this sport. And parkour popularity has grown exponentially, and it's been grown with a lot of teenagers and young adults, and that's where we do see again the injury patterns when they do come into our departments. They're typically going to be very young, and the injuries, as we'll see in a little bit, range from very minor to potentially severe. So let's take a look at an example of what parkour is. Just a quick video. And you can see, rather than use the stairs, we'll just kind of go right down the side of the building. So that is kind of in its infancy what parkour is. Parkour is a sport. Okay, now that's parkour in the adulterated version that the kids are doing. The parkour as a sport is actually a very organized sport. It's organized through the World Free Running and Parkour Federation. The WFPF is an international organization, tens of thousands of members, many, many practitioners who are using this as a very serious sport. Serious enough to where, quite honestly, this is being viewed as potential for it possibly actually becoming an Olympic event in the future. So, it is a very organized sport. And when we take a look at it, what it really is, this is what parkour is, or what we see it as a sport.
Of the United States of America. In the foreground, it's El Bucio of Mexico. Let's see who can get the first fastest time in. Which of the two will it be? This is the final of the women's speed competition at the Parkour World Championships. Audrey Johnson, El Bucio, and Bucio has suddenly made up ground.
You can just tell that they're going head-to-head, and they know this is a final, but there's some parts of the course where Audrey has an advantage just as she's smaller, she can go quicker, but Ella, has the leg power, is tall enough to maybe compact herself through those tight spaces, but at the end, it's just going to come down to who can touch that button first. So it's anyone's game, even though Ella's right now reigning with a little bit of a lead, Audrey's right behind her, and it could be anyone's game, and wow, what a race.
Yeah, so there you see it. I mean, really, it is, again, it's a very physical sport. And it's, again, using kind of an obstacle course type of a format. So that is free running / parkour as a sport. And who knows, you may be seeing it in the next Olympics. But because we are seeing a lot of youngsters doing kind of what I call an adulterated version of parkour, which is kind of going and using predominantly buildings as their main obstacle course, going from building to building, going from it could be in a more kind of more austere environment. We'll see some video here shortly of an austere environment where people are kind of going from mountains to mounds or little mountains to mountains. So it does, you can imagine if it's not done correctly, if you're not in good shape, if you're not practicing the way you should, then you can get injuries, and unfortunately serious injuries and even death to ensue.
Matt. This is Matt's tooth. And I'm gonna bring it back to him. It'll cost quite a few fucking dollars, mate, to replace them.
Yeah, so Matt just lost a tooth there. And in fact, they found that tooth was pretty amazing. But look at that fall that he took, and look at the fact that he had smacked his head, and it was a long fall. He could have had a lot of other injuries that Matt didn't have, other than chipping a tooth or breaking a tooth. So, as you can see, if it's not done correctly and it's not done really in the basic tenets of the way parkour as a sport is supposed to be set up, very dangerous, right? Yeah, so I'm not going to say anything more than, wow. Hospital foot. What is hospital foot?
And the next trick is called the hospital flip. Why is it called a hospital?
Yep. Cool as it lands you in the hospital, like a lot of these certainly can do. So again, these are not without their potential for causing injuries. Okay. And then there are what are called the epic fails. And you can only imagine what that means when it's an epic fail, right? Yeah. So, here you are, probably some, oh, I don't know, 20, 25, 30 stories in the air. Now you're going to jump between chasms or voids in a building. That's not the smartest thing in the world, right? So, what piqued my interest in parkour? As I've said earlier, it all came down to a case that presented to my shop in Patterson about 18 months ago. So we get a call from EMS. They're en route to us with about a 4-minute ETA. They have with them a 23-year-old female who fell somewhere between 2 and 3 stories from a building. Okay. So we're mobilizing this up. This was because of the distance of the fall, at that time, greater than 20 feet. But actually, since we were looking at possibly 3 stories, we're looking at something maybe on the order of potentially 35, plus foot fall. We went ahead and activated our highest level of trauma activation, which at my shop is a trauma code. Brings a few extra resources, brings whole blood into the trauma bay, things like that. And very quickly, we're able to kind of get up and meet the arriving EMS team when they arrive. In the handoff between our pre-hospital colleagues and the trauma team, we were informed by the EMTs, because they came in BLS, by the way, that the patient had jumped from either a second or a third-story window. They weren't really clear on that. Injuries, patient was really complaining predominantly of back pain, but they could assess no other or appreciate no other trauma. Patient was ANO times 3, complaining of severe mid-back pain. Vital signs were, as you see, a little tachycardic, pressure okay, respiratory rate a little elevated. And again, this was a BLS transport only. This was probably about 8 or 9 blocks from the hospital. EMS got there. She apparently landed, as she was falling between these buildings, landed in some kind of a debris catchment area, be it a dumpster or a pile of debris, which immediately after that kind of a fall, landing into a random pile of debris kind of brings you shades of, wow, what else could be going on, and what other injuries can she have that we're not seeing right now. But she did arrive, and she was hemodynamically stable. She was talking with us. She had a Glasgow of 15. We went ahead and transitioned her over. We started our primary survey. She had no uncontrolled external bleeding, pretty miraculous. From an AVPU standpoint, she was awake and alert. So she was, talking with us. She was aware of what was going on. She was answering our questions appropriately. Her airway was patent. There was no signs of trauma to the airway, no broken teeth, no blood, no swelling in the airway. She was phonating adequately, normally. So there was no concern about an airway issue. From a breathing standpoint, chest rise and fall was equal. She was a little tachypnic, but was not laboring in her breathing, but her respiratory rate was certainly a little higher than normal. Circulation, skin was warm and dry. She had a good, strong central pulse that was felt at her femoral artery. We did go ahead and do what all good trauma clinicians do, is we put 2 large-bore IVs in the patient. Didn't need fluid resuscitation now, so we weren't running any fluids into her. Had we been running fluids into her, we did have whole blood available in the trauma bay. Disability, her Glasgow Coma score was 15. She moved all extremities. The sensation was intact. She had no sensory deficits whatsoever. But again, we were appreciating the fact that she was complaining of some lower back pain. When we exposed her and removed her clothing, we put warm blankets on her, keeping her warm. And by the way, the IVs were hooked up to our level 1 fluid warmers. We kept her warm, and we noticed as we were pulling clothes off that there was some debris that was falling out of her clothing. There was some soil. There was some other particulate matter that was falling out, presumably because she fell into this whatever, either be at a dumpster or a pile of construction debris. One of the two buildings, if not both of the buildings, I think were under construction. She did develop, had some pain, complained of some pain once we got her over and we were doing our primary survey in her kind of her lower abdomen, kind of the substance pubis area. We went ahead and appreciated that. No other exam is going to be done down there. And we went ahead and did a fast on her. Fast was negative, no blood. E-fast again, nothing considerable there. Heart looked okay, lungs looked okay, good slide. Nothing abnormal. And then her first set of vital signs came in a little hypothermic. Technically not definition of hypothermic, but she's really close to it. Her heart rate was going up a little bit. Blood pressure was staying somewhat steady. You notice her pulse pressure is kind of narrowing just a little bit there. She had a shock index of 0.94, so we were certainly cognizant of that. We do kind of keep an eye on things like shock index and tidal CO2, her MAP in the trauma bay. Her respiratory rate was 32, so it was elevated a little bit over what was reported in the field. Her SAT was 96%, her end tidal was 38. So we certainly were watching her. We debated at this point in time whether we wanted to give her some fluids, but I mean, really, with her blood pressure being what it was, it really was thought that we should just hold back on IV fluids. But we did want to do a couple of interventions with her as part of our primary survey. So as you can imagine, we did pop her in a C-collar with that long fall, and the fact she was having some lower back pain that could have been a distracting injury. So we went ahead and popped her a C-collar in place. We went ahead and put a pelvic binder on her. That's our T-pod. So again, she wasn't displaying overt hypotension, but we certainly thought with an escalating heart rate, with our respiratory rate going up a little bit, we might be seeing, and her shock index of 0.94. So it was kind of teetering on the border. We decided, let's go with kind of the less invasive intervention that we could possibly do given her mechanism of injury. And that was, suspecting possibly she could have had an unstable pelvic injury. So we popped a pelvic binder on her and we used T-pod. We did give her some pain medication. She certainly was stable enough for that. And then again, we did put a hold on fluid resuscitation. It just really wasn't deemed to be necessary at that point in time. We moved on to our secondary survey at this standpoint. Her head, face, and neck were atraumatic, interestingly enough. Her chest, she did have a right chest contusion and some pain with palpation. There was no bony crepitus that was appreciated. There was no subacute air appreciated. Her lungs were deemed to be clear by the senior resident who was listening. Her abdomen was atraumatic, no pain with palpation, although again, we noted she did have that symphysis pubis pain. We didn't do any additional manipulation of the pelvis, pop that pelvic binder on. We also appreciated the fact that there was no bruising or discoloration in her perineal area, and she did not have any blood at the urinary meatus. Her flanks were atraumatic. Her extremities, she had some abrasions and contusions over her lower extremities, which you can imagine after a pretty long fall into some kind of a debris pile would be the least of what we would expect. And I think on her right arm, she had some contusions as well. Posterior, we didn't do a true log roll on her. Again, she had some back pain, so we were a little concerned given a long fall, and again with her possible pelvic injury. So what we did do is we did just basically about a 15-degree turn, just so clinician could get in there, palpate up and down the vertebral column very, very quickly. We knew she was going to be going to the scanner, but again, we wanted to make sure there wasn't anything obvious, especially since she fell into the debris field. So, did she have anything, impaling her in the back, anything like that we were not appreciating with her back pain? And we did find, obviously, a T-spot, a level somewhere around T3, T4, T5, they felt a deformity that was palpated. So we went ahead and we popped her back on her back, spinal motion restriction in place. And we then decided at this point in time, she's otherwise stable. We've kind of done our head to toe, nothing major going on. We popped a pelvic binder on her, and let's go ahead and let's get her over to the band scan. So what did the cat say? Well, cat showed us that she did have some injuries. And we weren't surprised by the injuries. We were surprised there probably weren't more injuries. She did have multiple rib fractures on the right. She did have a small right pneumothorax. It was pretty small. It was really rated initially as being less than 10%. And I looked at the scan photos not too terribly long ago in preparation for this, and in the reality, it was probably less than a like a 5% pneumo on the right. She did have burst fracture of T6 and T7, which was accounting for why there was a deformity palpated on her secondary survey. She had non-displaced fractures of T2 through 5 and T8. So, much of her T-spine had some vertebral column abnormality. She did have a paraspinal hematoma at thoracic T6, T7, but again, no impingement in the spinal canal, and obviously was not causing her any neurosensory symptomatology. She'd have multiple fractures of the pelvis, particularly again, multiple fractures, but fortunately nothing involving the pelvic ring. So she had pubic rami fracture, inferior rami fracture, a right ischial fracture, and then a left acetabular hairline fracture. So all of these really not great, but not creating an unstable pelvic environment. So we knew we were going to be able to take her pelvic binder down at this point in time. She also had a fracture of the sacrum and the coccyx, and then an incidental finding was an area on her liver, which was read as a hypodense mass. Certainly not believed anything related to the fall or the trauma, and to be followed up on a different day. So putting the puzzle together. So, again, we're always doing this. We're the detectives and trying to put some of these things together. And certainly when EMS and law enforcement came in, they were telling us the patient had a bit of a psych history, and they felt that she jumped, presumed she jumped out of the window. In our conversations with her, we've actually found a very interesting person who basically said, I didn't jump out of the window. I was jumping between windows. I was practicing parkour. I do parkour. It came out of her mouth, and we're like, "You practice what?" Um, and as you can imagine, those of us in the room who are probably a little bit older than our early 30s, or late 20s, are like parkour. Now, we didn't want to seem stupid, right? Because, hey, we're trauma clinicians. Come on. Blah, blah, blah. So immediately the phones came out and we started Googling what is parkour. We had a couple of residents who were in their late 20s who knew exactly what it was, and they actually enlightened us as to what it was. I got home that day, interestingly enough, and I asked my daughter if she had ever heard of it. And she's like, yeah, I've heard about it. We talk about it. I know some friends who do it. It's like, oh, great. So it is out there. It is the mainstream. Some of our population seems to think about it. Apparently, us older generation type didn't know too much about it, but we do now. But that's what it was. She basically was jumping between windows. It was a third floor of a building. Buildings under construction. They were doing parkour within the building because there were open pits and open floors and all kinds of fun stuff that you could get yourself into a world of other trouble from a traumatic injury standpoint with. But they had decided then they were going to building the building. They were going to jump out the window, and it was about an 8 to 10 foot distance between one window to another, going a little elevated down. And she went out the window and kind of hit against the building, and then kind of went down about 3 stories into this debris pile in either a dumpster or a pile that was kind of a pretty large pile from what we hear that was on the ground, which again, very, very lucky. Imagine what kind of debris could have been in there, what kind of objects, metal objects, penetrating potential objects that could have been in there. And then, that kind of a fall, that long of a fall for her not to have impaled herself on something is a miracle in and of itself. So, you kind of sit back and we're taking care of her, and obviously she's stable. The CAT scan showed us the injuries she had. None of them obviously are life-threatening. None of them are going to require anything other than really conservative interventions on our part. And then you begin to wonder, I mean, what kind of injuries, are typical? It is are typical from this. And like I said, went to the literature, and there really is virtually nothing in the literature on this. So I did reach out to, individuals through some of the social media platforms that are out there. I reached out on some email server lists that I belong to. I said, hey, this came into our shop. Have you ever had anything like this? And what did you find? And I actually had a couple of responses back. And most of what we saw were kind of the more minor stuff, right? Kind of the orthopedic injuries, the strains, the sprains, the minor fractures, things like that. A lot of soft tissue injuries, as you can imagine. Head injuries, nothing necessarily severe, although the potential for them certainly. And then facial injuries, again, owing to the fact that, the face is somewhat proximal to the head. So we got that. And then on the more serious injury side, and, this particular patient we had kind of ticked a few boxes here, were the vertebral column injuries, the spinal cord injuries. Fortunately, our patient did not have a spinal cord injury, although the potential was great that she would from that long of a distance. And she basically had a massive axial loading mechanism of injury. And she did have the burst fractures of a couple of her thoracic lumbar vertebrae and had some other fractures, stable fractures of the others. And, again, but no spinal cord injury. She was lucky. Straddle injuries, again, you saw that with the kid who was trying to jump the pool, landed kind of a straddling injury. Ouch for that. Straddle injuries can be commonplace. You can get urethral disruption from that. In this particular case, even though she was primed to have a urethral disruption, she did not have one. And she was lucky for that. And she did have, again, the anterior pelvis fractures. She had also the sacral and coccygeal fractures. She had ischial fractures, and she had an acetabular fracture. Again, she had all of the peripheries of the pelvis, but fortunately, the pelvic ring was intact. And again, lucky for her that was the case. In this particular case, because of the conservative nature of our treatment, really it was a matter of getting with our rehab folks. She had a custom brace that was placed that really she was supposed to have worn for, something on the order of about 3 or 4 months, in lieu of needing any kind of surgical intervention, because there really wasn't anything that they were going to do for her. And she would have discharged, I think, post-trauma day 4 for follow-up. And boy, this will shock everybody, lost a follow-up. So we never know really what happened to her, what her true outcome was, and whether she followed up on that incidental finding of the liver injury. So what are you to do as an emergency nurse? This patient comes into your environment and you're not a trauma center. What are you going to do? So again, it all goes back to what we hopefully learned in when we took TNCC, if you took TNCC, and that's starting off with, again, getting a very detailed history on the patient. Okay, this is your kind of, as you're triaging whether the patient comes in by ambulance or they come in by private vehicle. Putting enough information together to determine what's the possibility that this person is seriously injured or not seriously injured, right? If you're in a trauma center, the information that we got was pretty straightforward. It was a long fall. It met our pre-hospital trauma triage guideline activation rule, and it was long enough of a fall that we activated it at our highest level of trauma team activation. If you're in a non-trauma center and this person were to come in, and it's not uncommon they come in by private vehicle, particularly these parkour related injuries. We don't usually call an ambulance. We usually throw them in a car and take them to a hospital, if we even take them to a hospital. And what are you going to do? This is a person who fell 3 stories, is complaining of bad back pain, doesn't have anything bad going on at this point in time, but with that long of a distance of a fall, the better emergency nurses of us would be thinking this is a long fall, should be going to a trauma center and putting trauma transfer into effect in collaboration, obviously, with your physician providers. And then use that trauma nursing process. TNCC is great in that it teaches us this very detailed trauma nursing process, starting off with uncontrolled external bleeding, across the room look of the patient, and then moving down to our primary survey and then our secondary assessment. What do we find? What do we do? What kind of interventions might we do, like we saw in this particular case, or we did in this particular case? And then ultimately, how do we dispose of the patient? Where are they going to be admitted to? Or if you're not a trauma center, where are we going to be transferring this patient to? All right, let's finish this up with a quick video that just kind of goes over this adulterated version of Parkour in a variety of different environments.
Oh.
Bad monkey.
going?
Well, you kind of get the idea for what that's all about. You can certainly see from that video snippet that, yeah, injuries certainly could be very commonplace. And why we don't see more injuries than we probably reported, and so how somebody else hasn't written this up is pretty amazing to me. So these are a couple of references that I used. Again, not a lot that are out there. And like I said, I'd like to hear from anyone who's watching this video that's taking care of somebody who may have sustained a parkour-related injuries, just to kind of get a feel for what you saw and kind of what the underlying mechanism and of the injury was, and ultimately how that individual did. So this is my contact information. Please do email me if you have any questions, comments, or again, if you want to pass some information on about your own parkour case study, that would be greatly appreciated. And then again, take a look at some of the other videos that are available here at the Trauma Geek. I've got probably about 24, 25 videos that are posted. A couple have been flagged by YouTube recently. They must be on some kind of holiday frenzy of doing some reviewing. Some of them were taken down initially because they quote unquote did met their graphic. I exceeded their graphic content threshold. But these are like trauma videos, so yes, there's going to be graphic content, boys and girls. But do subscribe if you're interested. That way, every time a new video gets posted on the Trauma Geek, you'll get notification of it. We're sitting here about a week out from Christmas. So for those of you that celebrate Christmas and the holidays, happy holidays, happy Christmas, happy Hanukkah, happy Hanukkah, happy Kwanzaa, happy everything to you. So hope your 2025 was wonderful. And at the Trauma Geek, we look forward to seeing you in 2026. So take care, happy holidays all, and we'll see you later.